triglycerides are part of the food process for our muscles, for the first wave of these compounds in the LDLs or the VLDLs to feed the rest of the body.
Right.
So if those are too low, we're really inhibiting our basic functions to feed some of our molecular processes. And then if we're lowering the HDLs too much, where the ratios start to go, so the ratio of total cholesterol to HDL starts to go up instead of down, then we know that we're starting to become counterproductive. So, those are the two markers I look for. If I'm going to get people's LDLs that low, it's always going to be in the context of what their plaque situation looks like. If they have, and this is where that I mentioned the CCTA or some sort of imaging comes in, if they've got a lot of plaque on imaging, and if I see that they have inflamed plaque, then I'm really going to try to do the most that I can to lower that LDL for a few years.
Welcome back to another episode of the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Sherr, and it's a pleasure to be back with all of you. Today's podcast was fun. It was a tour de force on integrative cardiology, everything from diagnostics and laboratory testing to the cholesterol hypothesis, reverse cholesterol transport, and more with Dr. Abid Husain. Here is a bio on Abid. He is a triple-boarded cardiologist, integrative medicine practitioner. He's among the revolutionary few who are changing the way cardiovascular disease is addressed in medicine. As an established cardiologist in the conventional healthcare system, he experienced its benefits and limitations. Unwilling to settle and driven to learn more, he dedicated years to advanced education in functional medicine, bioidentical hormone replacement, anti-aging, biotechnologies, only to discover that these fields are unified in the study of cellular medicine. So he's been involved with Dr. William Seeds, and the Seeds Scientific Research and Performance Institute. This is where I met Dr. Husain about a year ago, actually. And now he actually works very close to where I live at the Boulder Longevity Institute with Dr. Elizabeth Yurth, who I've had on the podcast as well. So he combines his training and the application of individualized therapies from multiple medical disciplines to provide comprehensive cardiovascular care that is unique, preventative, and highly impactful. Through lab testing and non-invasive imaging, which we talk about during the podcast, he's able to identify patients at risk for heart disease and treat existing, subtle, and specific cardiac issues. He's also an accomplished painter, outdoorsman, and athlete. He's a really cool guy, and I like him a lot. His motto, is let's live long, live well, and have fun doing it. And so we had fun during this podcast. We really did go through a lot of information. And when you're talking about cardiology, I feel like this is just kind of par for the course. These days, there's so much to go over. But we started off with talking about the cholesterol hypothesis and how this came about. Some of Dr. Husain's or Abid's overall framework of thinking about LDL, HDL, and triglycerides, and the idea of reverse cholesterol transport, which he's very interested in. And we spoke about it in the beginning of the podcast, and we spoke about it at the end, but basically getting cholesterol out of our arteries, especially out of our plaque, is what he's really interested in now. Some of the new modalities and ways of sort of looking at certain markers of and medications as well, and how this is all kind of playing into it. So we talked about mitochondrial markers specifically related to HDL and triglycerides. LDL, we talked about the effect of lowering LDL on hormones in the brain and various types of medications that either are more lipophilic, that get across into the brain, or not, and some of the downsides of really going down too low on the LDL and sacrificing your HDL and triglycerides, and also sacrificing hormones and things like that. From there, we spoke about cardiac diagnostics, specifically related to the Clearly scan or advanced cardiac screening, looking at soft plaque, which is really interesting, and some of the newer imaging that's coming on the market, looking at inflammation in the blood vessel itself, cardiac fat, or the fat pad around the heart itself, and all these other really cool things that are coming down the pike. And then from there, we also spoke about laboratory testing, the types of labs that Abid is getting in clinic for his patients, both on the inflammatory side, as well as the advanced cardiac markers, which are super interesting. And we talked about ratios, ApoA versus ApoB, and other real, I think, important topics here. From there, we spoke a lot and spent a lot of time on inflammation when it comes down to cardiovascular disease. So we talked about really addressing the inflammatory side of cardiovascular disease, as well as the cholesterol part of cardiovascular disease, right? And where we spent most of our time was on the inflammatory side, because this is where I have a lot of interest, and Abid is using lots of really interesting interventions here. We talked about various medications, including hormones, like hormone optimization, talked about some off-label or repurposed drugs, really off-label like telmisartan and tadalafil, as well as the SGL2 and the and of course the GLP-1s as well, and how these are all playing into the world of addressing the inflammatory side of things. Then we also spoke about the Glycocalyx and some of the interesting things that are happening in that aspect. From there, we went over to the statins and the PCSK9s as well. We spoke about the differences and why you might want to use one or the other, and the pleiotropic effects of statins and why they could be helpful for other reasons, and being used for things like cancer and autoimmune disease and things like that. So this is a long introduction, but it's important because there's a lot in this podcast to take away. And I really hope you do. If you like this podcast, don't forget to like and subscribe below so you never miss an episode of the Smarter Not Harder podcast. Share with your friends and family. And now please enjoy this episode with Dr. Abid Husain. Hello. All right. We're all ready. Hello, sir. How are you today?
I'm great. How are you, Scott?
I'm good, Abid. It's really good to see you. Thank you for being here. And it's really exciting to have, I think, one of the people that's on the forefront of cardiology around the country from a lot of different perspectives, from diagnostics and therapeutics and novel cutting edge strategies. And Abid and I, you are both in the longevity docs group. We have a large network of longevity practitioners that we're affiliated with. And I always enjoy learning from you and of course at the Peptide World Congress with Dr. Seeds and Dr. Yurth. And so your reputation precedes you, my friend. So it's very,
well, thank you. That's very flattering. Appreciate that.
Yeah. So it's good to be here with you. And one thing I wanted to start off with, and as a cardiologist, I think a good initial topic is to talk about cholesterol, because this is a very hot button topic for so many different reasons. We've talked about this a little bit on our podcast, but not a lot. And I wanted to kind of dive in with you. So let's start with really broad strokes here. And how do you, there's lots of different ways of thinking about this, but how do you think about cholesterol now? How do you, and then from there, we can talk about some of the drugs that we use and some of the positives, some of the negatives, and then maybe some of the newer things that are coming along that you're really excited about over here.
Yeah. So, the cholesterol gets confused because there's so many different components of it. And I think a lot of the specific details of cholesterol get combined into one lump phrase, like cholesterol.
Right.
So we should divide this into specific compounds: HDLs, LDLs, triglycerides. And the debate about cholesterol is more often about LDLs. And where I stand right now is that cholesterol is important. We know this. And driving down LDLs is important in specific situations. And, we have studies that show that we can get plaque regression with low LDLs. But when I do that, I want to make sure I'm maintaining HDLs and triglycerides, because those have a different role. That's sort of the overarching message. But let's take a step back and maybe discuss like details of what is involved with all these different compounds and maybe why it's been so confused.
Yeah.
So, if we go back to, say, 1950s, like around 1955, Dwight Eisenhower had a heart attack, and it became a national emergency to figure out why, the president had a heart attack. And the researchers at that time came up with the theory that it was saturated fat. And it was a study called the Seven Nations Study. We look at this study in retrospect and find out that it was a flawed study. There was some issues with design, and there was probably some other interests involved to drive this idea that it was saturated fat. And in fact, when we look at this study in retrospect, it was more sugar, refined sugar, that was associated with heart attacks and not saturated fat. So
Right.
that part of it got debunked right off, debunked maybe 20 years ago when they did a retrospective. And the other thing is this study was not reproducible. When they tried to reproduce it, that association with saturated fat couldn't be made. Despite that, it led to the research into the idea that cholesterol was what causes plaque, and then it led to some of the ideas of how do we inhibit it, and hence cholesterol lowering medications. So even the inception of the idea that cholesterol is problematic for plaque is a little flawed. But when we look at the experimental science, it does bear out, because when we look at what cholesterol feeds, it feeds it also feeds the multiple things, multiple aspects. It feeds inflammation, it feeds muscle growth, it'll feed our immune system, cell membranes. There are these things called lipid rafts, which are which are messengers. It's signal transductors, things that will convey messages into the cell. So things feed, things are communicating with cholesterol, things in our body. And part of that is, viruses use that to communicate. Cancer uses that to communicate. So it's a very complicated issue to just simply think that cholesterol is associated with plaque, and that's the only thing it does. There's things that hijack our cholesterol metabolism for good and for bad. So, like most things in our body, it's ideal to keep it in a narrow range, or within a therapeutic range. And so the challenge is that even in patients that we do that with, some show up with atherosclerosis. They show up with problems, with cardiovascular problems. So how do we kind of differentiate who is at risk and who isn't? And that's where we have to look at advanced markers. We have to look at imaging, things like that. I've used the term cholesterol, but oftentimes, like I said, when it comes to plaque, we're talking about LDLs. Triglycerides are important. They don't have as much of an impact on plaque formation as LDLs. And HDL are those compounds that actually can remove cholesterol from our arteries. So those are the compounds that are still very much, the details of which are unknown. We know some of the dynamics, but it's still a very complicated compound, and the ability to pull cholesterol from our arteries is still not something we really understand in detail.
So you mean the ability for us to pull cholesterol that's already in the arteries out of the arteries?
Yeah.
Are you talking about into plaque itself, or are you just talking about in general how we pull cholesterol out of the arteries to get to where they need to go?
Yeah, specifically in the plaque, because that's the area where it's most relevant. But
Right.
This happens it happens constantly all over our body. So, you may have heard the analogy that our body is making cancer cells all the time.
Of course.
Our immune system
Yeah.
that is clearing those. And so plaque is, in my mind, very similar. There are areas in our body where we will be depositing LDLs. They'll stick to the wall, cause cholesterol to deposit, maybe form some soft plaque. And then we have HDLs that are constantly coming in and removing those.
Got it. So I like that analogy. I haven't heard of that one specifically, but of course I've known it, in the cancer world for many years. We're making cancer cells all the time, and like we're making plaque all the time, but we have this ability to recycle and to maintain. But so what I understand what you're saying here is that what we're trying to figure out now is how we can take cholesterol or these deposits themselves when they've already formed and then reverse them, right? And so what's some of the new research or what's going on in that capacity that you're excited about, or what's happening there?
Yeah, there's a lot of work that's going into what are called CTEP inhibitors. And they tried to release a compound probably about 5 years ago, maybe a little bit more, which was thought to be that rate limiting step or the integral step to try and help improve reverse cholesterol transport. And that's what this process is called. It's called reverse cholesterol transport. There was I think it went to phase 3 trials, and then it stopped because there were poor outcomes. So this is a complex compound and a complex process, and we still don't know how to manipulate it the right way to improve that.
Gotcha.
Cholesterol transport. But this is the space that I'm most excited for the next 5 to 10 years, because if we can figure out how to manipulate this process, I think that we can make a lot better strides in helping atherosclerosis, and do it in a way that is not as, has as many side effects. The problem with lowering LDLs is that it comes with side effects when it's associated with certain medications. And then there's the debate of whether how much is too low, and who needs to have their LDL and who doesn't, reduced.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our foundational module, Metabolomics. If you want to regulate inflammation, you have to regulate cellular metabolism, energy metabolism, vitamins, minerals, cofactors, how the environment interacts with all this. This is what you learn during Metabolomics. So if you're a clinician, if you're somebody that sees patients or clients, check out Metabolomics. Go to homehope.org and save 10% on this module or any module at homehope.org by using code podcast10 at checkout. Now back to the show. Yeah. I mean, so this is an interesting argument or interesting topic because I have seen some retrospective studies in your centenarians, for example, and or people very old or older than the average, like 90s, 100s. Yeah. Typically, these patients, before statins came around, right, they would have higher LDL levels, and there was some thought that these higher LDL levels were protective on some level and to help with longevity and and sort of in that capacity. What's your sense of that? Is it just that some people don't have like the other aspect of it, which is like the fuel on the flames, like the inflammatory aspects that are just as a result of that, they can have a high LDL and not have, cardiovascular disease or have any issues related to it?
Yeah, I think it's a combination of things because these LDLs will feed the immune system. And in a person that has a well-tuned immune system and the ability to pull cholesterol appropriately, that's an ideal situation. And that's where you find the centenarian. That's the ideal profile for someone to be able to deposit, feed the immune system, and then remove what's becoming problematic. When we have a standard American diet, when we live with inflammation, when we are sedentary, and or exposed to toxins, that interferes with that process. And then it just takes one block to be removed. And then we start to develop plaque.
Got it. So it's the balance between immune system activation and maybe reverse cholesterol transport as part of it, right? Sure. And then also their ability to remove that cholesterol as needed as it gets deposited. So
because I mean, if you think about a centenarian, someone that's lived well, long, and healthy, they have an immune system that is robust. Right. They have an immune system that is active, but still knows how to regulate inflammation the right way. On the other side of the coin, if you have somebody that's metabolically off and generating chronic inflammation, this is a person that we don't want to feed their immune system. Their immune system is dysregulated, and so having high LDLs is problematic. Right. So you got it's a very specific population that does well, and we have to try and get those metabolically off people back into or get them closer to this other profile.
That makes sense to me. So the way you think about it, I guess, and maybe I don't want to take the words or put words in your mouth, but it sounds like these higher LDL levels are causing more of an immune system activation. And then as a result of that can cause more inflammation. So that's one of the processes that you could potentially see dysregulate the whole system.
Yeah. It's fuel to the fire. Yep. And so if you have a fire, we have to reduce the fuel immediately. And depending on how hot they are, how much risk they're in will determine how aggressive we have to be and how long. So, and then if they're not that hot, then we can work on the fire itself to quell that. And then, we may not need to be as aggressive with the LDLs.
Got it. Okay. So it's all about the patient in front of you and what you need to do right now, right? I think that's when it comes to, I always talk about this in clinical medicine. It's like, you can look at numbers, you can look at somebody in a book or whatever, but like it's not, or information in a book, but it's like the person in front of you is going to have a lot more complicated nuances when it comes to actually seeing them, right? So
yeah, totally. Yeah, I mean that's the way the appropriate medicine is going to be. I mean that's the way. Unfortunately, modern medicine is going to have to go in that direction. We want it to be population-based, and it's not working when it's population-based.
100%. And that's the kind of personalized medicine that I know you're all about, as I am. So when you're thinking about some of these philosophies, and I've talked to some cardiologists like this, where we want to get your LDL down to 10 or 20 or as low as absolutely possible.
Mm-hmm.
And maybe they do have risk factors, right? Maybe it is somebody that has some plaque formation. They have a cardiovascular history in their family.
Mm-hmm.
Do you think that there is there a too low in here, Abid, as far as you're concerned?
Mm-hmm. It's too low when it starts to lower the HDLs and when the triglycerides get too low. Those are the two factors that I look at when I'm doing it at the expense of those other cholesterol compounds. Triglycerides are going to be a marker of triglycerides and HDLs are a marker of mitochondrial function, number one, and number two. Triglycerides are part of the food process for our muscles, for the first wave of these compounds in the LDLs or the VLDLs to feed the rest of the body.
Right.
So if those are too low, we're really inhibiting our basic functions to feed some of our molecular processes. And then if we're lowering the HDLs too much, where the ratios start to go, so the ratio of total cholesterol to HDL starts to go up, instead of down, then we know that we're starting to become counterproductive. So, those are the two markers I look for. And once, if I'm going to get people's LDLs that low, it's always going to be in the context of what their plaque situation looks like. If they have, and this is where that I mentioned the CCTA or some sort of imaging comes in, if they've got a lot of plaque on imaging, and if I see that they have inflamed plaque, then I'm really going to try to do the most that I can to lower that LDL for a few years. And,
Gotcha.
I think that the concern is, okay, what's that going to do to my brain? What's that going to do to the rest of my body? Well, your brain makes most of its own cholesterol. There is some that goes across the blood-brain barrier, but LDLs don't. So that compound is not impacting our brain. So we don't have to worry about that. Sometimes we need to inhibit the immune system a little bit. I mean, and then, it's not, it takes a long time for the body to notice the downstream effects of certain interventions like cholesterol management. So a few years of keeping it low shouldn't impact anything long-term as far as we know.
As far as, a couple of things kind of come to mind. First, to go back, you mentioned that HDL and triglycerides are markers of mitochondrial function, or how do you think about that?
It's they provide the fuel for oxidative phosphorylation, and then in the mitochondria itself, there are enzymes that catalase and superoxide dismutase, which get lower will get consumed if there's a high reactive oxygen species, meaning if the mitochondria are not functioning efficiently, if they're burning fuel it's like a bad car engine. If it's burning fuel poorly, the more smoke that comes out and the less heat it generates, the worse it is. It creates reactive oxygen species, and our body will consume those. It will try and manage those, but it does it at the expense of other things. So what'll happen is if our mitochondria are not functioning well, so if we're not getting the right fuel in, and we're not burning triglycerides the right way, then that creates reactive oxygen species. Enzymes that consume it that reduce it get consumed and then can't be used for other functions like reverse cholesterol transport, like impacting HDLs.
Understood. Okay, great. So you think of those as mitochondrial markers in the sense of when you're looking at optimizing somebody's lipid panel, you don't want to make them too low because it's also going to affect mitochondrial function if the HDL and triglycerides are low, regardless of what else it's going to be. And there may be issues, right? Mm-hmm. And you mentioned, and I think this is something that I have heard from cardiologists, and I know that that our brain makes our own LDL, so that's supposedly not affected by being on statins or
Well, the caveat to that is some statins do cross the blood-brain barrier.
They do, yeah.
So even though the brain makes its own LDL, the impact of medications may do something to the brain, depending on whether which one you're using.
Gotcha. And that's an important point. We can talk about that in a little bit. And then also, one of the things that comes up a lot, at least in my practice, is hormones. When it comes to having somebody's LDL be super, super low, or if it's related to medication specifically in this case, have you noticed issues with testosterone levels or estrogen levels or things like that are steroid producing hormones overall?
I have, but it's not in everybody.
Not everybody.
There are some particular individuals where starting a statin will impact their testosterone production. So, and it's noticeable for them. They will feel fatigue. They will, and once we check the lab, we'll see, okay, it's testosterone that's gone down. Or if it isn't that, then it's the mitochondrial effect. But yeah, it's a minority of people, but I have seen it.
Okay, gotcha. And so I think this kind of goes to, you're talking about CCTA a couple minutes ago while we were chatting. So let's talk about some of like the best sort of cutting edge diagnostics out there when it comes to, and then maybe also some laboratory tests outside of cholesterol that you kind of look at as a corollary, because getting a CT scan now, you can get different types. So let's talk about what's out there. What are you recommending for most of your patients? And then how are you correlating that, obviously to your cholesterol panel, but other labs that might be helpful, as a physician, because the audience of the people that are listening are a lot of clinicians here. So I'm going to want them to refer to you and other, advanced cardiologists, but they're also going to be able to do some basic stuff in their clinics.
So let's start. Historically, we'll still start way back. Historically, what we used to assess plaque in the arteries from a surrogate standpoint was the carotid intimal medial thickness. And that was because the artery is close to the surface, easily imaged with an ultrasound. It's inexpensive. It looks at the lining of the artery, gives us an idea of thickness of the lining. And if it's thick, it's more inflamed. That would give us indication. Secondarily, what's going on in the coronaries. Good, fair correlation. So if we start to see plaque here, the assumption is we can believe that there's some there. So large scale studies say that there is an association of outcomes, but not necessarily that plaque is definitely there. So that evolved slowly into, okay, we've got to image the heart directly. And at the time, because the heart is such is in constant motion, it's hard to image. It's got to be done in between the beats, and CT imaging wasn't able to do it at that time. So the only thing they could do was a calcium score, a quick shot of imaging to see what the brightest stuff is in there, which is calcium. That lights up the brightest on a CT scan. So it only tells us what is at the end phase of plaque. So plaque starts as cholesterol deposits, and if those cholesterol deposits linger enough, they will become inflammatory, and the immune system will start to try and stabilize it.
And that's oxidized plaque versus non-oxidized plaque. Is that right?
Yeah, that's right.
Okay.
Yep.
Sorry.
So we got the plaque gets oxidized, and then that becomes foam cells, starts recruiting a lot of other inflammatory compounds, and then it will calcify. And so in the middle, the area where it's probably the most metabolically active is you get this mixed plaque that's got activity of stabilizing, and then at the end of the spectrum, it becomes calcified. So a calcium score just looks at the end of the spectrum and maybe what's peppered in that middle phase, that mixed plaque phase. So if you have a high calcium score, it is a definite indicator that you're at high risk and you need to look further. If you have a low calcium score, it doesn't eliminate the fact that you might have this soft plaque. So people would get calcium scores, and then they would still die. It's like having that classic story of a patient that does a stress test, and then a month later they drop dead. It's because they're only getting end stage disease that's severe. So now what we have is a CCTA, which is CAT scan with angiography. So we can look at the coronary arteries in a good scan, and with slowed heart rate enough, so it's got to be below 60 beats per minute, we can get good imaging that looks at the actual anatomy of the arteries, the degree of stenosis, and then it tells us if there's mixed plaque, soft plaque, or calcified plaque. And then taking that one step further, which is where a lot of this new data, this new technology is coming from, is taking those images and then processing them through an AI platform to look at each pixel, look at each one of those images in super detail, and tell us what the density of those compounds are, or the density of that space, and then tell us, that tells us if it's hard plaque, soft plaque, inflamed, and then exact amount of stenosis. So,
And yeah, go
yeah,
ahead.
I mean, the one that we know of is clearly that we use frequently. There's another. There are others that are coming out that are in the space that look at different inflammation from different processes, but essentially they're all doing the same thing. The one difference is there's a company called HeartFlow, and they don't look at the pixels. They look at what's called FFR, which is flow through the arteries, and that's more of a functional process. So a little nuance there, but clearly is in my mind the best option for outpatient prevention.
Part of the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal choky. For this episode, check out our Tromune. Tromune is a high-strength extract of the cordyceps mushroom, cordycepin. It is much more potent than the mushroom itself to improve your immune system function, to increase your deep sleep, to fight infection. So you take it at night, and it helps with mitochondrial optimization because you sleep better, your immune system is more optimized, and your inflammation levels will go down. We talked about NF-kappa B during this podcast. This is something that Tromune decreases as well and downregulates. Go to transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show. Got it. And so as far as your recommendations now for people, do you feel like everybody should be getting one of these as a baseline if they can sometime in their like late 30s, early 40s or later? Or what's your usual recommendation at this point?
Yeah. If you have a family history, if you're not sedentary, if you are sedentary and if your metabolism feels off, then I think you need to get one of these because you're going to need to get it eventually assessed whether you get a calcium score or not. So right off the bat, you can afford it. It's definitely a great baseline test. If you're healthy and you think that if finances are an issue, then a calcium score potentially. But remember, it's not the definitive test, but it's something. But then you got to do it again after a few years to see what's happening in sequence. So in my mind, the best test in one shot and the best peace of mind and best investment is doing that CCTA.
And how often, if somebody has, I guess it probably depends on what how severe the coronary disease is, for example, but how often are you typically repeating these in people? Is it it's a CT scan, so this is going to be radiation, but I know they're doing lower radiation than most, but what's your sense of how often do people repeat them overall in general?
It depends on what we're finding. So if it's somebody that's got inflamed plaque, then I'm going to do an aggressive treatment protocol, get them scanned after a year. If there's no progress, gives me some idea of what may need to be adjusted, and then do it again after a year or so. So it depends on what we're looking at. If it's somebody that's got high-grade stenosis, 70% or more, and or inflamed plaque, that's an annual CT scan. If it's somebody that's got lower than that, moderate disease, maybe no inflammation, then we can push it out for maybe 2 years. If it's lower than that, very mild, then 2 plus 3 years, something like that, 4 years.
Got it. Cool. Understood. So if you're doing some of these tests and you're getting some of these results and you're seeing maybe mild or maybe even severe plaque here, maybe severe is kind of a different section. Maybe let's call it like mild to moderate, right? Somebody that doesn't have a lot of risk factors, but what other lab tests are you using in corollary? Not only obviously the cholesterol panel, but you can talk about that in various ways if you have specific ways you think about it. But what other markers are you looking at? So for example, I guess my question is somebody comes in, you wouldn't just put somebody on aggressive treatment or maybe even mild treatment if they had some mild plaque but no risk factors, but you probably have other ways of triaging people, right? So what are some of those ways?
Yeah. Well, one thing I want to point out is that this is rapidly evolving science, and there are no real guidelines to tell us how to navigate patients in this way. Because there's no population studies and we're doing this on an individualized basis, everything that I'm doing is based on science. It's based on experimental studies
Right.
and some population data as far as the treatment goes.
But no
But
no AHA guidelines is what it comes down
yeah,
to.
there's
Right.
no
Yeah.
AHA
Yeah.
guidelines. This is happening too quickly for
Right.
them to be able to keep up to date. And so a lot of this is, what we're figuring out
Yeah.
through observation. So
Yeah.
it's important to remember that. Yeah.
Yeah. Yeah. So with lab tests in general, then, like, what are the ones that you're using now as a way to kind of correlate what you're
Yeah.
seeing on imaging?
So everyone tests C-reactive protein. That's a great and vital introductory test. There's tons of data that correlates C-reactive protein with cardiovascular outcomes. It's a
Right.
useful test, and it's a good introductory and initial biomarker. The problem is it's non-specific. It's not specific to the
Right.
vascular system.
Right.
So everybody that comes to our office gets a C-reactive protein. They get a PLAC score or LPPLA2, which looks at the more of a vascular marker. We'll get an oxidized LDL. We'll do a myeloperoxidase, small dense LDL, and then we'll do an LDL. Potentially, if they don't do small dense LDL, then a particle test. So those are some of the basics. And so let's go over those tests individually.
Yeah.
I talked about the C-reactive protein. So correlates with cardiovascular outcomes. The problem is it's non-specific, so other things can increase it, and that's why we need vascular specific markers. Because if C-reactive protein is high, and say some of the more vascular specific ones like PLAC are low, then I know that something else is going on, like an infection or some other injury or some other process.
Right. So you're able to delineate. Gotcha. Yeah.
So LPPLA2 or PLAC, essentially the same test, is a test that looks at it's an enzyme really that will convert those LDLs into more oxidized LDLs. So PLA or LPPLA2 often elevated by high LDLs themselves, smoking, inactivity, high carbohydrate diets, and vascular inflammation. So what that will do is drive the LDLs to become oxidized, and so we can measure that as well in the serum. Now serum oxidized LDL is not a great marker because the oxidized LDL is much higher in concentration, up to 70% in the plaque itself. But it's, it can still be used as a gauge for what might be floating around. And secondarily, like if it's lower in the serum, then it might be lower in the plaque. So not perfect, but still an indicator. And then small dense LDL really gives us a specific understanding of that LDL composition, because not all LDL is bad. And if LDL is small and dense, it's more like a bullet that will penetrate that lining of the artery. If it's large and not dense, then it's like a beach ball, and it floats around the inside of the artery and kind of bounces around and delivers the payload and doesn't really cause a problem. So getting a measure of the small dense also gives us a more specific understanding of how inflammatory or pathological maybe those LDLs might be.
Gotcha. Is there any more tests that you missed that you do typically use, or you said myeloperoxidase, right?
There are some specific tests that I like to do. I do like to look at the gut in everybody. When it's possible, a TMAO, and that may not be done right away, or it might be done a little bit later on. The trimethylamine oxide, and it is a indicator, kind of a rough indicator of gut health. If your gut microbiome is off, it can produce an inflammatory makeup, and then that will make the colonocytes, the gut lining, become more permeable. Compounds like choline will get into your system without being properly digested or metabolized. And then once it does that, the liver will actually convert it to TMAO, and that's more inflammatory. So it's a little bit of a few steps, in process to get to that TMAO compound, but it is an indicator that something's going on over here. So I like to look at that one. There's a lot of other biomarkers that are marketed as being vascular specific, and they are. Problem is, a lot of them have a lot of confounders, and they may not be as relevant or as useful in some of our clinical decision making. So sometimes I prefer not to use those because they confuse the picture sometimes.
Yeah.
Microalbumin to creatinine ratio and ADMA, SDMA. Those are supposed to be markers for nitric oxide and or kidney function, and they are that, but those are very variable. Nitric oxide is dynamic, changes constantly, and so does our kidney in response to inflammation. So there could be day-to-day changes, and even something as simple as a heavy workout can make those fluctuate and cause a confusing picture.
Yeah, one that gets thrown around a lot now, and it's been more popular, is the ApoB marker. And ApoB. And so, how do you typically use that one, or use ratios, or what's your use of that particular marker?
Yeah, I like using ApoB because it can give me a specific understanding of atherogenic compounds. So the difference is LDL measurements that are used traditionally look at just mass, the total amount of cholesterol,
right?
And that doesn't quite give us an accurate assessment of atherogenic potential, because if it's cholesterol that's in all the big LDLs, well, that's not a problem. That's going to float around and bounce around and not cause any issues. But if it's a lot of cholesterol if it's cholesterol that's in a bunch of these small, dense ones, that's a problem. And so if we have high amounts of ApoB, that tells us that one ApoB is associated with one particle of LDL. So the higher the amount of ApoB, the higher the amount of particles, and then probably the more amount of those are small and dense. So ApoB, also that protein, it's a lipoprotein on the outside of the LDL compound that helps it grab onto the lining of the artery, and it's a 1-to-1 ratio, and with LDL to ApoB, and so it's useful, and it can be used in calculations also to understand that ratio of HDL to LDL. So ApoB is on LDL, ApoA is on HDL. And so we look at that ratio, and we want the ratio of ApoB to be low, so below 0.6 ideally.
Got it. Okay, cool. I mean, as far as any other, you talked about the CCTA. I mean, I'm going to get to medications and interventions here in a minute. But any other cool advanced diagnostics that are coming around that we should know about, that we'll be hearing about in the next 3 to 5 years? Or is it more just kind of iterating on getting these CCTAs better and getting more plaque understanding, or maybe using less radiation? I don't know. What's going on in the future? Do you know?
Yeah. The radiation aspect is pretty well dialed in. It's just a matter of all of the centers starting to get to that same protocol, the same standard. If we in a good center with a high quality CT scan that uses the right amount of radiation, they're only doing the equivalent of maybe 2 mammograms per full CT scan.
Okay.
And then the contrast agent is down to maybe 70 milliliters, where they used to be 150. So we're really refining how little to expose people to get this information. And the CT scanners, the easiest way to understand their resolution is by thinking about it in the terms of slices. So a good CCTA scanner, top of the line right now, is about 256, and high resolution, most scanners are around 8 slices, and lower than that, your quality of imaging is going to start to be compromised. So you get a good high quality CCTA, and then all of the tech right now is looking at ways to crunch that imaging. So whether it's Clearly, whether it's another company called Lucid, there's Carry Heart. These are all different AI-based platforms that already exist, looking to get rolled out into the United States. Different ones look at different things. One of them looks at inflammation in the lining of the artery in more detail to actually maybe detect portions of the endothelium, that artery, which might be inflamed before plaque shows up. So there's that. There's another one that looks at epicardial fat. So there's a lot of studies that show that the amount of fat around the heart muscle is indicative of plaque and adverse events. So it looks at that and combines it with a arterial imaging also. But in the prevention space, that's where most of the tech is right now.
That's super cool. Yeah, I went down to Denver for my CCTA when I got there, clearly, and it was the first time I ever took metoprolol before, and it was a strange experience, man. Like my heart rate was low. I mean, my heart's always low, but when I remember I was on the phone driving down, and I was like getting more, I just wanted to like more expressive about something. I wasn't getting angry or upset or anything, but I was like, what's happening here? Like there's some sort of weird disconnect. Like I'm trying to get excited or enthusiastic about something, but I just can't. So it was an interesting experience to do it, but it was very easy. It was very quick. And you're not in I was actually shocked at how quickly the whole thing happened when I actually got into the scanner. So it's not like a long procedure or anything. So
no, it's not. In the best case scenario, and in a well-prepped patient, it doesn't take much time. It's, maybe a half hour from start to finish.
Yeah, that's great. Yeah, so that's cool. I didn't realize they're looking at inflammation in the arteries, pericardial fat, like this. They are looking at, it kind of looks like, it sounds like to me, very similar to what we're doing now on the sort of what's called the omic markers, right? Your genomics, your metabolomics, your proteomics, like looking at all these various levels and trying to crunch that data. So I'm sure that's what's going to happen eventually, right? Is you're going to be able to crunch all the data from all these kinds of variations in software and then figure out what the best plan is as a result of seeing all that, right? So
I think that only the proteomics and metabolomics are going to play a part, but that still means deciphering the pathways and what metabolites are doing what and how we change those. What we know right now is that plaque is an indication that you're at risk for more plaque. So and going back to the biomarkers, I will look at somebody's, look at both of those. I'll look at their inflammatory load and their plaque load and use that to make a decision of how to treat them.
Yes.
If their plaque load is low and they have high inflammation, then that's a different treatment than somebody that's got high plaque and low inflammation, because that happens too. And it's very, very, and that's why, we need to have both of those pieces of data to really understand what we need to target,
I love it, because that's like the perfect segue, because that's exactly where I was going to go next is like you have people with high plaque, low inflammation, you have people with high inflammation, low plaque, and then you have people, of course, that have both high inflammation and high plaque, right? And so when you're thinking about various ways of intervening here, so you're thinking about the inflammatory side, you're thinking about the plaque side. Obviously, they're not mutually exclusive, but tell me a little bit about your thought process, or what's your overall framework on how to approach it?
Yeah. If I see high inflammation but low plaque load, I don't have to be as aggressive with the LDLs, and I'm going to focus on all the compounds that are going to change the omics, change their epigenetics, their proteomics, and change their metabolism.
Well, how about we start there? Let's start off with those. Like, start off. What are some of the things that you're working on when you see lots of inflammation but low plaque burden overall?
Well, the basics are going to be there. We see lots of inflammation, so we got to start aspirin, omega-3 fatty acids, check their vitamin D, do those basics.
Of course.
See what their vascular health is, make sure that they're getting the right precursors for nitric oxide, because nitric oxide is a powerful anti-inflammatory. So we got to make sure they're getting the right precursors from their diet. If need be, then we'll give them some supplement for nitric oxide. My preference is to use compounds, peptides, hormones, things like that impact your body's enzymatic ability to make nitric oxide, as opposed to just giving a precursor.
So what would be some examples of those?
Yeah, I mean, testosterone is my favorite one.
Of course,
it's it does so much for our body in so many different ways. It helps your vascular system, in physiologic and even mildly supraphysiologic ranges. Definitely therapeutic for your vascular system, improve nitric oxide. So that's where hormones come in, and then also estradiol. Very important for vascular health and for HDL management. So, let's see, we talked, so aspirin, vitamin D, omega-3 fatty acids. Those are some in
your hormones. So like your testosterone, your estradiol.
Optimize hormones for sure. And then we got to look at the most useful agent that we have to help stimulate the right epigenetic changes right now are GLPs, GLP-1s, GLP-GIPs, and then we've got the triple agonists. All of those, they are amazing compounds that at any dose will slowly impact epigenetic changes.
And this is the inflammatory side of things we're talking about, right?
Yeah.
And
so,
yeah.
If we think about it in the most fundamental level, what these compounds do is they help improve how your body is making proteins. They impact not only the mitochondrial health, but endoplasmic reticulum health to improve proteins to be folded the right way. And by doing that on a cellular level, there's just profound different benefits that happen immediately and then downstream.
And you're saying that, and you said initially, or just a minute ago, about any dose of these. So talk a little bit about that, and maybe also, if you can, delineate a little bit between the different classes there, your GLP-1s and then the multi-agonists and things like that. So tell me a little bit about those.
So any dose, meaning all the studies and that look at the impact of GLP-1s. They are looking at therapeutic doses with weight loss and with control of blood sugar. Most of the studies are in diabetic populations. There's the obesity studies, which are non-diabetics. So those are doses that are going to be therapeutic. So if we're talking about semaglutide, we're looking at 0.5 and above. Usually 1 to 2.5, 2.4. And then with tirzepatide, it's going to be 5 to say, I think it goes up to 15. And then I think retatrutide, which the triple agonist, the doses on that are still a little bit to be worked out, but I think it's, I want to say 4 milligrams, but don't quote me on that.
Okay.
That's the starting dose, and you work up from there. Those studies at those therapeutic doses show benefit, but a lot of people are using microdoses now. We call them microdoses, but they're sub-symptomatic, sub-therapeutic doses.
Right, they're not for weight loss per se, right? They're more for this, and that's kind of really where I was going with the question is, where are we with that? What kind of experience have you had so far using some of these doses and some of these drugs?
I think they're really useful because when we look at how it improves mitochondrial function, there are people that come to the office that are off. They're chronically ill and their mitochondrial function is off. We don't want to, we want these medications help improve that mitochondrial efficiency and help to bring it back slowly. But we can't use them at high doses. So we use them at those starting doses. And at those ranges, we see slow benefit. So, and then even a person that's healthy, that doesn't need to lose weight, there's the belief that it does improve inflammatory makeup, and that the low doses will have a slow additive effect.
And have you seen that in clinical practice so far? I mean, I know they haven't been around too long, but I'd be interested in some of your experience because I know everything that's been going on with GLP-1s and then these multi-agonists and things. And I also want to talk about the SGLT2s as well, because I think that this is also part of that category, I believe, as well. But what have you seen, at least clinically? Have you seen people like that have just added these and now they have plaque regression, or like that you've seen stability, or what have you seen, at least clinically, that's been very exciting for you?
I see that there's better fuel utilization, and oftentimes their energy levels will go up. We'll see more efficient use of the fuel sources in different tissues too. For instance, looking at adding low dose GLP-1s and using it with combined hormone replacement therapy, oftentimes they overlap and will improve, say, muscle health, muscle recovery, reduce inflammation in muscles. When I'm looking at plaque regression, yes, we see plaque regression, but oftentimes it's not in isolation with one agent. So
you're doing a lot of different things. Yeah, I get it.
GLP-1, but oftentimes in those patients that need plaque regression, they're also, they have some weight to lose. We know there's inflammation to reduce, so they're getting therapeutic doses. But so at the low doses, it's sometimes hard to tease it apart. But I believe that it's part of the cocktail that gets them feeling better and feeling, sometimes better than they have, in their entire life.
Wow, that's awesome. And do you have a preference as to which one you're using now more as far as the GLPs, or do you have,
Yeah.
is that a,
I'm using more tirzepatide these days. I like the semaglutide mostly because the data is all on the GLP-1 and with semaglutide, especially outcomes data for cardiovascular health.
mm,
We're waiting on the outcomes data for tirzepatide, but looking at the experimental data and the pathways, it makes sense that it's going to do similar, if not better. Um, what we do see is that there's probably a plateau of how much benefit these agents can have, which is
mm,
around 20%.
okay,
And I think that that'll plateau at mid-range doses also. So,
okay.
and tirzepatide has a lower side effect profile.
Okay,
Mhm.
gotcha. And then I know, we talked about nitric oxide. What is your use, or how are you using tadalafil in these cases? Or,
Yeah, that's right.
yeah.
So as part of the treatment protocol, we talked about the agents so far. I really like the use of tadalafil and telmisartan. Both of those agents have pleiotropic benefits that are just really wide ranging, and at low doses that don't cause hypotension and or other effects, they can have profound benefits on nitric oxide, inflammation, blood flow. They can even be fasting mimetics.
Really?
Telmisartan specifically, let's start with that one.
Yeah,
Uh,
start there. Yeah, yeah.
there's multiple pathways that it will not only improve nitric oxide, but reduce inflammation via NF-kappa beta, inflammasome activation. Improving blood flow will also by itself lower inflammation and improve recovery.
Mhm.
It improves exercise performance. There's data looking at improving neurologic health and potentially treatment of prevention for dementia.
Mhm.
That's just by the blood flow improving effects alone, not to mention the neuroinflammatory benefits. So the dose I'm looking at is potentially 2.5 to 5 daily. And then you got to play it by ear with the patient because there's some patients that metabolize it a little more slowly, and I go to every other day dosing. But it's an easy, cheap, and useful medication that has wide ranging pleiotropic benefits. And then you combine that with telmisartan. Telmisartan is a blood pressure medication in the angiotensin receptor blocker category, generic, been around for decades. The unique thing about this compound is its structure.
Mm,
It's a angiotensin receptor blocker, and by doing that, it has the specific vascular benefits by blocking angiotensin and angiotensin 2. And what that does is it that provides anti-inflammatory benefits on its own. But the structure of telmisartan is similar to it's an AMP kinase activator too.
right.
So it's very similar to other structures that activate AMP kinase, and because of that, it's got a lot of downstream anti-inflammatory benefits and performance benefits, and they overlap. Those two compounds overlap nicely, sort of in a dovetail, to really provide multiple anti-inflammatory, tissue-specific, and vascular benefits.
So what's your dosing typically of the telmisartan when you use it?
20 milligrams. 20 is usually not enough to impact the blood pressure.
Mm,
And then, take it daily. And since these are not necessary medications, but for augmentation and for maybe health span, necessary for somebody that might have inflammation and vascular disease.
right. Right.
If
Yeah,
it's
I
not
understand.
in that,
Yeah.
if it's not somebody that's got significant vascular disease, maybe you cycle it too.
Right. And I think that the key here is that you're not talking about every patient being on all of these
Yeah.
medications, right? You have a lot of choices, and then depending on the individual that's in front of you, you're going to make
Mhm.
those choices depending on their data, their capacity to take various things. And we
Yeah.
know it's not very easy for people to be compliant overall. But one of the other drugs I wanted to ask you about was colchicine as well, because I know this drug's
Yeah.
been around for a long time, and it's coming now. We've used it for pericarditis since I was in training, and I'm sure you
Mhm.
were as well. How are we seeing it now being involved in the inflammatory side too of
Yeah.
cardiovascular disease?
Colchicine is a great addition for somebody that's got plaque and they've got inflammatory markers that are elevated. It's an easy add-on at 0.6 milligrams a day. It's well tolerated. There's a company that has released a 0.5
Yeah, I
milligram
know.
dose.
Yeah.
And, is there really a difference between that 0.1 milligram? I doubt it.
It's a lot more money, right? And it's like
Yeah.
ridiculous, because that's the dose that they patented overall. So
Mm-hmm.
yeah.
So, but 0.6 milligrams a day there's some studies so the study that put it on the map is the Colcott trial, which looked at people right after a heart attack, started on colchicine 0.6 a day, and they showed reduced events in 6 months. Because in that 6-month time frame is when someone is most vulnerable for a subsequent heart attack.
Makes sense.
So that's why we got to treat him hard and treat him aggressively right in that post-event period.
Nice.
So in a patient that's got inflammation, really useful. There's been there are 2 other studies that got released. One showed no benefit. The other one has shown benefit. So this is one of those things where it's important how we utilize it. And,
right.
The good news is that it's well tolerated and it's got a lot of anti-inflammatory benefits.
Right.
So the way colchicine works is that it changes how the white blood cells, the macrophages, move around and get to the areas of inflammation. It works on the microtubules.
Microtubules, yeah. I remember back from medical school.
So it changes the movement of the macrophages, and that has a lot of multiple downstream effects. It reduces NF-kappa beta, reduces inflammation, reduces all the cytokines that go along with that. And so in an inflammatory situation where someone's hot, someone's had an event, very useful. In a situation where we see that there's multiple vascular indicators or biomarkers elevated, and especially if I see oxidized LDL elevated, definitely an indicator. And then if I see hot plaque, inflamed plaque on their clearly scan, also a definite indicator.
Cool. What about SGLT2s? I know you've done a lot of work, and I listened to one of your lectures at the Peptide World Congress last year on SGLT2s. What's your sense of their role overall? And maybe you can describe what they are real quick.
Yeah. I'm a big fan of SGLT2 inhibitors. They are another diabetic medication that's been out for many years. Not quite generic, but really a useful and powerful medication on multiple levels. They're a pill, and what basically they do is they make you pee out more glucose and more salt.
Right.
Now, it sounds like a simple thing, but that has profound downstream benefits. We've seen incredible benefits in the heart failure population because it changes how our body regulates fluid. And in heart failure, that's a major disruption. There's a major problem there. And so it's done dramatic things for the heart failure population. And then also it started as diabetic medication. It's another really useful tool to help control blood sugar. What we see is that it is also a fasting mimetic. So it stimulates the same pathways like that we stimulate with telmisartan in the sense that it stimulates AMP kinase. So it tells the body to turn on the mechanisms that it does when it's fasting, when it doesn't have to be fasted. And why is that beneficial? So why is that a positive thing in telmisartan and in SGLT2 inhibitors? Because when we're fasted, our body has to search for different fuel sources, become more efficient at utilizing the fuel it has. And then it's going to break down inefficient compounds and garbage that's floating around that's disrupting our efficiency. And it's going to break those down, autophagy, and it's going to recirculate them and become more efficient. So it's an important process, and it's not something that we need to stimulate constantly because we're cyclical beings. We break down, have efficiencies, become fasted and then build. So we need to do both of those.
Right.
And this helps your body regulate that, and it also optimizes that autophagy AMP kinase sort of pathway. And SGLT2 inhibitors have a really interesting effect of reducing scar tissue and fibrosis. Yeah, through the TGF beta pathway, which stimulates a lot of fibrotic cascades, it will reduce fibrosis in the kidneys, potentially in the lungs, and every tissue that has the receptor for SGLT2. So, the more we look into it, the more it has benefits in complicated medical conditions. From a vascular standpoint, from a cardiovascular standpoint, it improves nitric oxide. It improves the turnover and the health of the endothelium. It improves the progenitor cells, which is the sort of those stem cells that help to replace the endothelium. So there's a lot of different mechanisms which it is useful in helping vascular health.
Yeah, I know you've done like hour-long lectures on all the benefits of SGLT, these particular class of medications. One other question on the inflammatory side, and then maybe we'll finish up with the cholesterol part with it, is on the glycocalyx itself. Like we've talked, this is more being talked about, and I just wanted to get your take on what your sense is about the glycocalyx and stabilization, anything that we've discussed here that, I'm guessing all the inflammatory downregulation is also going to help stabilize it, but maybe you can talk a little bit about the glycocalyx, maybe what it is and how you think about it in the context of what we've discussed so far.
The glycocalyx is it's a polysaccharide, a glucopolysaccharide layer that's around the endothelium. So it's the first layer of compounds that protects the endothelium.
Right.
And it's a really interesting structure because it fluxes, it grows and shrinks depending on our fed state, depending on our inflammatory state, and that is one of the things involved with protection of the endothelium. The problem is the only way to visualize it, measure it, is actual visualization with a ultrasound-based device. And I think
like intracoronary, like intra, or is it?
No, not intracoronary. It's more in the carotid.
Okay.
Yeah, and that device is it's hard to. It's an expensive device, and I think the implementation of glycocalyx therapies is more based on understanding. It's more based on faith than it is, seeing this improve, because not everybody's got the capacity to test this. It's a specialized device and it's not readily available. It's only in a few offices. So the offices that have it, then they're lucky enough to be able to really visualize it and see if it's working. We know that certain compounds can improve the glycocalyx. And so in a patient that got a high inflammatory burden and I'm not seeing, the responses that I want, then I will consider adding that, some of those precursors. But also there's some repurposed medications that really help the glycocalyx. And one of those is pentosan, polysulfate.
Gotcha. And so you're saying that, so only specialized imaging can really detect the glycocalyx at this point. And then if they're doing it, it's going to be carotid glycocalyx. And then do we think, or do we have any knowledge from a research perspective if that's going to be correlated to coronary glycocalyx, or we don't really know?
Don't really know. There's data that looks at, there's definitely associations with cardiovascular health. But looking at it in the coronaries, I haven't seen that being done.
Gotcha. Yeah, I know when I had Dr. Yurth on the podcast here, we talked a lot about pentosan sulfate and a very cool medication. Are there any other ones you're thinking about from a glycocalyx stabilization, or is it sounds like this is sort of like a third, or it's a multi levels in the sense like this is not the first place you're going to go, right? But if you start seeing the benefits of the inflammatory support, and then we'll talk about the direct cholesterol management, then this is another piece that you can kind of bring in, is what it comes down to.
It is. And oftentimes it's not something I'm going to do in isolation.
Sure.
What ends up happening is there's going to be some sort of gut dysbiosis, or in some sort of indication to use something like pentosan. I'm going to try and find not a single-use compound, but something that's going to help multiple systems.
Yeah, that totally makes sense. And I love, when we talked about laboratory and diagnostics, you mentioned the gut. And I think that's a big part of all this, right? Is like looking at the immune system activation piece, right? Why is the system immune optimized? Why is it immune optimized? Why do they have more inflammation? Yes, it could be cardiovascular where you're seeing it, but still, what's the question? Like, where is the why? Like, where's the, like, obviously the diet is going to be a big part. Lifestyle is going to be a big part of this, but like checking their metabolomics, for example, this is something that I do in clinical practice, is something that you can optimize their, their vitamins, their minerals, their nutrients, their gut health. So I know that's a big part of, what also you're looking at with precision medicine and cardiology, right? So
definitely.
Yeah. So when it comes down to the LDL, the cholesterol thing, and maybe in the next, maybe like in about 10 minutes or so, we can go through, I know it's like a long. So tell me, like, why should we put statins in the water, Abid? Like, this is like this is like the cardiology argument, and please don't do this, please don't. But like, but statins versus PCSK9s and others out there. How do you think about using them? And I know there's obviously risk factors for all of these on their own, but tell me a little bit about how you frame it for your patients in your practice.
I don't think everybody should be on a statin. It's it depends on the individual. If their metabolomics are doing well and they're able to manipulate their total cholesterol and those subfractions well, then I don't see a need to do that. It's not an ideal agent. It's got a lot of positive benefits to it, but it's a mitochondrial inhibitor. So, you heard me talk about the importance of mitochondrial health. So, we have to take that into consideration. It's got an appropriate use need. And in patients that come out of the hospital hot, patients that have plaque, they've declared to me that they are a risky patient and they need to be treated with something more aggressive. And so I'm going to use a statin on those kind of patients.
For sure. And then when you use the statins, sorry to interrupt. And when you use statins, do you have like ones that you particularly would use and not use? Like, for example, we were talking about earlier, the ones that are lipophilic, the ones that can get across the blood-brain barrier, the ones that can't. How do you think about that?
I prefer using rosuvastatin. Gets a better effect on the HDLs. It's got a robust effect on the LDLs, and it won't pass the blood-brain barrier.
Got it. Okay. So then you use statins, obviously, if there's hot plaque, if there's like, there's really good research in the sort of secondary prevention market for sure.
Remember, statins they have a lot of clear benefits, meaning benefits that are outside of just that one specific use. They're being looked at in cancer prevention. They're being looked at in autoimmune disease. They're being looked at there's even data that says that it actually helps brain health by reducing senescent cells in the brain. So there's, it's not a perfect medication, and a lot of people get side effects, and there are ways we can work around that. But I am not going to throw out use of the medication if I see that there's experimental data that shows benefit. And I'm not talking about data that shows very little, overall, that just has like relative risk reduction. I'm not, I'm looking at absolute risk reduction, but also a lot of that old data didn't have the right population. It didn't have the right dosing. It didn't use rosuvastatin. So, and the mechanism with which we lower LDLs is also important. So we don't want to use a statin? Fine. There's other medications now that we can use that lower LDLs in a different way. So that's the PCSK9 inhibitor. PCSK9 inhibitors they don't impact how your body makes cholesterol. Statins block how your liver makes cholesterol. PCSK9 inhibitors will keep that intact. Your body makes the same amount, but it reabsorbs it better. So the receptors that grab onto the LDLs and bring them inside the cell, those get recycled better and they don't get degraded. So then this way your body pulls it out more effectively. It's tissue specific, so we'll pull it back into the liver, and so you can excrete it or reuse it. So then the concern is, have we seen it cause increase in fatty deposition in the liver? Not seen in studies so far. So in a patient that is high risk, the preferred agent would be a PCSK9 inhibitor. And if it's still not reaching the target, then potentially a statin as well. the PCSK9 inhibitor is an expensive medication. It's hard to get
It
approved.
is.
So
Yeah.
oftentimes we have to resort to using a statin.
Right. And so you talk about the statins pleiotropic effects as well. And I have seen it used in cancer and multiple different things. Is that, do we sense that that's an inflammatory reason that it's pleiotropic is in general?
Yeah.
Or do we have another idea?
I think it's the reduction of lipid content, and cholesterol lipid content is what our immune system uses as fuel. So
Right.
if we have an uncontrolled immune system and we're reducing the amount of lipid being delivered to that immune system, then it's going to reduce the inflammatory burden or the ability. The challenge is, is that's got to be balanced out with mitochondrial issues. So,
Right.
that's probably why we're not seeing a robust benefit, and which is why, it's got to be used carefully. And which also means that we can replace the compounds that are not being made in the mitochondria. There's ways to improve mitochondrial function and still, reduce the fuel if we need to.
What are some of those ways, briefly?
You can use, CoQ10 is important,
Of course.
but
Yep.
Not all CoQ10 gets into the mitochondria. So if you're going to use CoQ10, it should be ubiquinol.
Right.
And then there's a mitoquinol, which is a proprietary compound which says that they can get the CoQ10 into the mitochondria, into mitochondrial membrane, into the inner part. It's expensive, but it's useful. You can also use an inexpensive supplement called geraniol, which is a precursor to CoQ10, and your body can take that and put it in. And there's studies that show that it reduces muscle discomfort or myalgias that are statin induced. So the theory is that it gives a precursor to your mitochondria, and then your mitochondria can actually make it in that space.
I haven't heard of that one. That's why I have to look that one up. That's cool. Yeah.
So that those are some options. Anything that's going to help the mitochondria, and that can be in the form of a peptide. It can be antioxidants, N-acetylcysteine. I mean, any things that improve your superoxide dismutase and catalase.
Cool. Are there any other meds that you're using primarily now in sort of the cholesterol aspect of things? As far as we talked about, the PS, and we have we have statins. Any other ones that you're using regularly at this point?
When I see an inflammatory patient, and when I'm trying to think about the other side of the equation, the inflammation and maybe the reverse cholesterol transport side of it.
Yeah.
I like using apigenin. Apigenin is a really useful supplement that reduces oxidized LDL, improves. There's some data that says it may help with reverse cholesterol transport, but it's an antioxidant. It's got a lot of pleiotropic benefits too. This is where hormones come into play again, improving that reverse cholesterol transport. There's other. That's where my focus is.
I see.
In that area, and there's. As far as peptides go, we can look at GHRHs and GHRPs,
right? Growth hormones,
and they help the vascular lining, and they can also potentially help reverse cholesterol transport. So they're useful in metabolic health, in improving our athletic performance, but so many other benefits from these compounds. And like GLP-1s, they can stimulate production of the right genes so that we have downstream benefits that occur after years of use too. So
nice. Yeah, I've heard you talk about apigenin before, and that's a new one for me. That for this particular ecosystem, we're making. I know that it also works on the GABA system as well, and that it can be used for sleep at night. So people take it. People take it at night, and we have something at one of the companies that does like at prescriptions. We're actually making one that has apigenin in it as one of the compounds. So that's super cool. But I could speak to you forever. This has really been fantastic. I have tons more questions, but I'll stop it for now. So keep people interested. I mean, there's so many more topics that we could talk about. We just kind of scratched the surface, but I ask everybody at the end of the podcast, one question. So the name of the podcast is called the Smarter, Not Harder podcast.
Yeah.
And at the end, I ask everybody, what are 3 ways that we all can live smarter, not harder? And of course, we've been talking about cardiology this whole time. We've been talking about diagnostics and laboratory testing and therapeutics and things like that. So it could be related to that, or it could be entirely left field and something not related to this podcast at all. But what are the 3 ways you think all of us can live smarter, not harder?
Yeah. I think one of the most important things that we don't give ourselves the permission to do is to get enough rest days. I think the people that listen to this podcast and people that are, that want to really tackle cardiovascular health or fitness, we're type A personalities, and giving ourselves rest days feels like, we're not making progress when we have to be making progress every day, doing something. So I think that, working smart to let ourselves relax, recover, do something like meditate, do something that's a restorative activity like yoga that's not hot yoga, something that's just stretching, restorative, easy on our bodies.
Sleeping's good too.
Sleeping. And then I think, and then keeping things light, not everything has to be serious. Not everything has to be hard driving. Mental health is probably one of the most important things that we have to look at that doesn't get addressed. And, when we look at cardiovascular health, mental health is very much a part of it.
100%. Yeah. Anything else? I think that was 2. I think you got the rest and recover, and you said working on mental health and Anything else?
Aside from that, a balanced exercise, getting a mixture of resistance, aerobic activity, and then having that rest day. I think that would be my prescription.
I like it. Good thing from a cardiologist. So, I would tell us a little bit about your practice, where you are, if it's open, where people can find more out about you too.
Yeah, thank you. I am at the Boulder Longevity Institute. I'm taking new patients, and what do we do there? We assess people from a thorough standpoint, like we talked about here. We'll do a full blood panel that looks at all these inflammatory markers, all these biomarkers, hormones. Our belief is to improve health span and try and improve lifespan. And, from my perspective, cardiovascular disease is still the number 1 killer. And I want to make sure that that's addressed, whether you've had a cardiac event or not. And then optimize your health in every way possible. Doing it from a metabolic standpoint, which definitely helps your heart, but helps the whole system too. So I've spaced in my schedule and taking active cardiac patients as well as longevity patients.
Amazing. So it's boulderlongevity.institute.com, I think, right? Is that it? Cool.
Boulderlongevity.com.
Well, boulderlongevity.com, right? I know there's an institute as part of that where you do a lot of teaching and training with Dr. Yurth, and you can find Abid on a stage at the peptide congresses and some of those others. And so if you're a clinician, you'd find him over there. I'll probably see you in Vegas in June over there, which will be great.
We've got a discussion, which will be fun.
Yeah, that's going to be great. I'm excited to see you there, but it's really a pleasure to spend some time with you. I know you're just down the road from me, 30 minutes south near Denver. And I'm close to the office, and I'm going to try to come by sometime soon, at least when you're there, and say hello. And maybe get some free exosomes. But have a great rest of your day, man. Enjoy your weekend, and we'll talk soon. Okay.
Yeah. Thank you for having me. You too. Bye.
Thanks so much for tuning in to another episode of the Smarter, Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. It was a fantastic podcast to record with Dr. Abid Husain. I learned a lot about cardiology, interventional cardiology from an integrative perspective. We talked about cholesterol. We talked about diagnostics, therapeutics, laboratory testing, some of the newer medications that are coming out there. It is a fantastic field. And if you're interested, he does a lot of speaking, Abid, and he also has an open practice. He's here in Boulder, very close to where I live. He's taking patients. Go check him out at the Boulder Longevity Institute. If you like this podcast, don't forget to like and subscribe below so you never miss an episode. And we'll see you next time on the Smarter, Not Harder podcast. Take care.